I'd like to thank the moderators for the opportunity to present this research. And again, I'll be presenting laparoscopic sleeve gastrectomy is an independent predictor of poor follow-up and weight loss following bariatric surgery. We have no disclosures. There's currently conflicting data regarding comparative weight loss outcomes after sleeve gastrectomy and gastric bypass. However, most current literature quotes comparable weight loss outcomes between both procedures, averaging about 60 to 80% excess body weight loss by 2 years. However, there are a subset of studies that have demonstrated reduced weight loss for sleeve gastrectomy, both in terms of early and long-term weight loss outcomes. Interestingly, in reviewing our own institutional data, we noted that not only was our overall cohort falling short of this metric by 2 years, but when we stratified by surgery type, our sleeve gastrectomy patients were losing significantly less compared to our gastric bypass patients, and we wanted to elucidate the reason for this phenomenon. We know that there are a multitude of factors that impact post-surgical weight loss, including surgery type, eating behaviors, patient characteristics, changes in metabolism, exercise, physiology, baseline comorbidities which impact our metabolism, and multidisciplinary follow-up. Therefore, we wanted to know if within these characteristics that we know are important for weight loss, are there suboptimal patterns represented in our sleeve gastrectomy population that are potentially accounting for their reduced weight loss. The study objective was therefore firstly to characterize difference in our sleeve gastrectomy versus gastric bypass cohorts in terms of these variables, including baseline comorbidities, education and socioeconomic status, and multidisciplinary follow-up, and secondly, to see if these baseline differences accounted for the reduced weight loss outcomes we had observed. The first part of this study was a retrospective review of all patients who underwent primary bariatric surgery at a single institution. We stratified by surgery type, and compared them in terms of baseline comorbidities, socioeconomic and social status, and post-surgical follow-up. In comparison to patients who underwent gastric bypass, patients who underwent sleeve gastrectomy presented with significantly lower baseline BMI. They had lower incidences of obesity-related comorbidities, and as well were less likely to be bipolar at baseline, and were more likely to have college or greater education. They also trended towards being more likely to be male, having less major depression and less psychotropic medication usage at baseline, as well as being more likely to be married. So we looked at comorbidities and patient characteristics, and next we wanted to evaluate multidisciplinary follow-up. As you can see, when we characterized no-show rates, we had a marked increase in no-show rates as you progress from 6 months, 12 months, 24 months, and 36 months, to approximately 70% by our 36-month follow-up, with the majority of these accounted for by our sleeve gastrectomy patients. Sleeve gastrectomy was significantly associated with no-show rates compared to gastric bypass at 6, 12, and 24 months, but was comparable at 3 years. In fact, on multivariate analyses, sleeve gastrectomy remained an independent predictor of no-shows up to 2 years post-operatively, even when we adjusted for baseline comorbidities, prior weight loss outcomes, and socioeconomic variables. Therefore, in summary for this first part, we found that sleeve patients in our cohort were more likely male, they were more likely to have college or greater education, presented with decreased comorbidities, and were, however, associated with decreased postoperative follow-up. So the next question was to see if these factors were potentially accounting for the discrepancy in weight loss we had noted at 2 years. For this, we took our same cohort but stratified them by whether they had poor, being in the lowest quartile, versus good, being in the highest quartile of excess body weight loss at each time point, and determined predictors of poor weight loss at 1, 2, and 3 years post-bariatric surgery. At 12 months, predictors of poor weight loss included sleeve gastrectomy, followed by increasing intake BMI, having less than a high school education, while having a high school education or a high school diploma was protective. At 2 years, independent predictors, again, sleeve gastrectomy was significantly associated, as was African American race, and having a baseline diagnosis of major depression. Interestingly, anxiety disorder was protective. At 36 months, the predictors of poor weight loss at this time point included sleeve gastrectomy and having no-shows at 6 or 12-month appointments. This demonstrated that even when we adjusted for characteristics that are known to be impacting reduced weight loss after surgery, sleeve gastrectomy still had an independent relationship with reduced weight loss, which suggests that either we are not accounting for variables that might be explaining this, or potentially there are anatomic reasons for this. Despite the fact that we couldn't fully explain the association, we did want to know if there were characteristics that predicted poor weight loss after sleeve gastrectomy specifically, and if so, how do patients who have these characteristics do after gastric bypass? Similar to our second part, we took our sleeve gastrectomy cohort, but now stratified them by poor weight loss, which we defined as less than 37.5%, which was the average of our lowest quartile at each year, and looked at the proportion of patients who were within this metric at 12, 24, and 36 months, and compared them to patients who had successful weight loss, which we defined as greater than 60%, and that was the lower limit of what is currently cited in published data, and looked at the proportion of patients who had achieved this weight loss outcomes and compared these cohorts within sleeve patients. Similarly, we found that at 12 months, baseline hypertension, African American race, and major depression were predictive of poor weight loss, as was having less than a high school education. At 2 years, baseline major depression and no-shows at 6 months were predictive of poor weight loss after sleeve gastrectomy. And at 3 years, having a binge eating score of 1 or more and no-shows at 6 and 12 months were independently predictive of the outcome. So we took these predictors and we defined them as high risk, and we stratified our patients by whether or not they had 1 or more of these characteristics at 12, 24, and 36 months. And within these high-risk patients, compared the proportion of patients who had poor weight loss following sleeve versus poor weight loss after gastric bypass. In doing so, we found that sleeve gastrectomy was associated with significantly higher proportion of patients having poor weight loss compared to gastric bypass at each time point, which actually resulted in nearly a 2 to 3-fold increase in the relative risk of having poor weight loss compared to gastric bypass within patients with these high-risk features. In summary, our cohort showed consistently lower weight loss outcomes after sleeve gastrectomy, and that this reduced weight loss seen following sleeve gastrectomy was not fully explained by typical medical predictors, or including follow-up medical comorbidities and socioeconomic status. However, high-risk characteristics, such as higher baseline comorbidities, lower education status, and no-shows, did seem to impact sleeve outcomes more significantly than they did gastric bypass outcomes. The study is limited by its retrospective design, and it's a single institution experience. As well, poor follow-up, as we showed, which could be dramatic at 3 years, could skew our results. And finally, anatomic reasons for weight regain are not accounted for in this study. In conclusion, given the rising rate of sleeve gastrectomy procedures and the declining rate of gastric bypass procedures, I think these studies, as well as the conflicting data on weight loss, suggest a need for larger and externally validated studies evaluating comparative weight loss outcomes. And furthermore, studies such as these that identify risks associated with poor weight loss after sleeve gastrectomy may ultimately help guide decision-making and potentially help patients choose the most appropriate bariatric procedure for them. Questions?